Hello and welcome. My name is Benjamin, and today I'm going to talk about nephrotic syndrome. So the purpose of this video is going to be about basically the basics you need for mostly your examinations. The topic of nephrotic syndrome, and when you look at nephrotic syndrome, it's one of the diseases of the glomerular apparatus of the kidney. And for it, it's going to be characterized by a triad of having hypoalbuminemia, heavy proteinuria, and generalized edema. And this is going to always come as a consequence of the damage to the podocytes, which are responsible for prevention of the filtering of the proteins. So when we look at the causes of this syndrome, some are going to be positive, some are going to be secondary, some are going to be primary. And the secondary ones are due to other diseases that are known basically intrinsic to the glomerulus. Then we have the primary causes, which after eliminating all other causes, we realize there is a reason and it's just something wrong going on with the glomerulus, and those are the primary causes. And basically the three most common are minimal change, focus segmental glomerulonephritis, and the membranous nephropathy. But when we have secondary causes, they will cause a histological pattern that tends to resemble these ones in the primary category. So when we look at for example, when we look at atopy, boil atopy, when you look at NSAIDs, you look at Hodgkin's lymphoma. Somebody with Hodgkin's lymphoma is very capable of developing nephrotic syndrome, but the kind of nephrotic syndrome they will develop, when you do the histology, it will appear as the minimal change, which is a primary disease of the kidney. So these secondary causes are going to cause a pattern of disease that looks like the primary cause. So when you look at minimal change disease, it basically derives its name from having almost not visible abnormal changes when you look at it histologically under a light microscope. But when you look at it with an electron microscope, you may see some podocyte effacement, and this is going to be it's generally not going to be so different. Yeah, it's not so specific. Podocyte effacement may still be even in other forms, but the word minimal change comes from what you see, and minimal change is mostly going to affect children. If it affects adults, the prognosis is not that good. Especially if the response to the steroids is not really good. But the good thing about it is self-limiting. That is mostly where in most people it's self-limiting, and therefore development of chronic kidney disease is rare. Then the next one is the focal segmental glomerulonephritis, and this one basically is associated with the West African descent, people from West Africa or the blacks, and it is associated with the APOL1 gene, which is commonly found in those people in the West Africa. And when you look at it under a light microscope, there will be segments of sclerosis, and sometimes when you do actually a biopsy, you may not get the segment that is affected. So you end up picking probably a part of that nephron, look at it, and it may appear as minimal change disease. You may not see much changes with that, maybe some podocyte effacement, and you may be tempted to confuse it for minimal change disease, but actually it is what? A focal segmental glomerulonephritis. Then there is a membranous nephropathy, and this one, it is just due to the diffuse thickening of the glomerular basement membrane and diffuse capillary thickening. So that is what you're going to see when you do histology, and it's the most common type in the Caucasian population or the whites, and it's associated with the M-type phospholipase A2 receptor on the surface of the podocytes. So one of the important things is the role of a third about this membranous nephropathy, whereby a third of the people that are affected with it are going to attain spontaneous remission, and a third are going to remain nephrotic, while a third may progress to end-stage renal disease. So when we are managing nephrotic syndrome, most of our management is going to look at complications of the disease, and we try to treat them accordingly. But we have to know where the complications are going to come from. Most of our complications are going to come from damaging the podocytes. When you damage the podocytes, those ones are found in the glomerular basement membrane. The kidney's ability to filter proteins to prevent the extravasation of proteins is going to be lost. So we are going to lose proteins, and typically when you do a 24-hour urine protein estimation, you'll find that it's more than 3.5 grams per kg, sorry. And Because of this loss of proteins, you're going to have a decreased oncotic pressure, and a decreased oncotic pressure, which is the pressure exerted by the proteins like albumin majorly in the blood vessels that is supposed to prevent the extravasation of fluid from the blood. It pulls the fluid within the blood vessels. So when we lose that protein, fluid is going to move into the interstitial space, and that will release into the generalized edema. And edema of nephrotic syndrome, or generally in edema originating from kidney disease, normally will start with the periorbital swelling, will be very common, and then it will go downwards. Unlike those ones we see in liver disease, heart disease, those ones will be discussed in their own videos. So after losing the proteins, we lose also some coagulation factors. And this is very important because these people, DVTs, outclots in their blood vessels more easier. And this is because there is a relative loss of the urinary anticoagulating factors. So the reason they say urinary relative is because you're losing both the coagulation factors and the anticoagulation factors, and that is mainly antithrombin 3, protein C, and protein S. But the difference is when the body is losing, there is this trying, the body tries back to produce more of these clotting factors back. But the half-life of the clotting factors in relation to the anti-clotting factors is very different. The clotting factors have a higher half-life. So as they are being lost in urine, again, they are also dying out on their own. But the anticoagulation factors are even having a shorter half-life compared. So you realize that the more we lose them, we are losing them in the urine, but also we are losing them to their own lifespan, their short half-life. So in the end, when you compare the procoagulating factors and the anticoagulating factors, the procoagulating are going to always overpower because of their higher half-life. And these ones that are dying even while still being lost will always be lower, and then the person will develop a high propensity to develop these thrombi. Then when we look at non-specific liver lipoprotein synthesis, now what happens is that we are losing proteins. So the liver tries to metabolize and produce more proteins to replace the ones that is being lost. And as it is doing that, it does it in a non-specific way. It goes on and produces everything. We end up with increased lipoproteins, and these ones are going to include your HDL. It's going to include your LDL. So HDL is going to actually be low when you look at this. When you look at maybe a lipid profile of a person who has this, the HDL is going to be low, but they're going to have a high LDL, and they're going to have increased triglycerides and everything else. So you realize that what we call the bad cholesterol is going to be high. And then still, as we are losing these intravascular proteins, we're going to have reduction of the fluid in the volume, and the kidney will decide to activate the RAS system, the renin, angiotensin, aldosterone system. And this is going to lead to increased water retention and sodium retention, and this is going to lead to also the edema. So the edema is under two hypotheses, which are known as the overfill and the underfill hypothesis. Yeah. So in the overfill, it is due to the activation of the RAS and the retention of increased sodium and water. But when you look at the underfill hypothesis, it's going to be due to the decreased oncotic pressure. Yes, as we talked about, due to the loss of the proteins that then will lead to fluid going to interstitial, and then we have generalized edema. And then lastly, we have urinary loss of immunoglobulins. And now these immunoglobulins are important in the fighting of infections. So when we remove them or when we lose them, infections are going to be easily gotten by these patients. So we may sometimes consider vaccination or giving prophylactic antibiotics, but the giving of antibiotics in this particular syndrome does not actually, or is not advised in some guidelines, or does not offer any additional benefit to the recovery of this patient, because as you can see, the problem is not mainly associated with an infection. When we are managing this patient, we shall do some investigations. A lot of investigations need to be done. You want to check for autoimmune antibodies. You want to check the blood for albumin levels, lipid profile, creatinine. You want to do a urine spot creatinine ratio and And the spot urine creatinine ratio has been very important because this is a one-time test you can do. You get the patient's urine, you check the ratio. If the ratio is higher than 3, then this patient has a problem. They have nephrotic syndrome, and you can begin the management even before you head on to the 24-hour urine protein, which will take a lot of time. So the 24-hour urine protein is not done in some cases, in preference to spot urine. Then the macroscopy, you can do blood, you can do a renal biopsy, as we have said, to diagnose this minimal change, focus segmental, membranous nephropathy. You may need a biopsy. And mainly a biopsy is going to be required whenever we probably don't see an improvement with the administration of a steroid, because as you can see, some of times when you're managing, the response to the steroids may be not good. There may be some cases whereby we have something refractory and the steroids don't actually help, and then realize then other drugs will start to come in. So we can use calcineurin inhibitors, we can use ACE inhibitors that help suppress the proteinuria. So remember, the ACE inhibitors are going to constrict the efferent arteriole, which will reduce the pressure in the glomerular apparatus, which will reduce on the extravasation of those proteins into that. So ACE inhibitors are going to be important to suppress this proteinuria. We can use loop diuretics whenever we have the edema to relieve symptoms. Yes, we can give loop diuretics together with maybe thiazide diuretics and many. So the management will not be discussed very fully, but because it will differ from guidelines of different countries. But at least this is a very good and concise approach to glomerular disease. So if you like more such content, such videos, you enjoy this, I would encourage you to subscribe and leave a like. Thank you very much.